Welcome to the Clinical Cousins YouTube channel. This video is going to be on TTP, Thrombotic Thrombocytopenic Purpura. So what is this condition? Well, this condition is a condition of thrombosis or clot formation that has thrombocytopenia with it, or low platelet count, that can cause purpura. Purpura is a purplish-like rash which is caused by the small vessels bleeding under the skin, which if it can bleed under there and create that, it can also bleed on organs. So what separates this condition from DIC, that's also a thrombotic condition that can lend itself to bleeding, is the way in which it causes bleeding or causes platelets to be consumed. So we need to understand a little bit about what goes on in clotting again. So in this specific condition, we're going to talk about von Willebrand factor. So von Willebrand factor is like the glue of the blood. It's what we use to grab a hold of those platelets and coagulate them and form them into clumps to stop bleeding. It's one of the primary methods our body uses to stop bleeding is platelet aggregation. So von Willebrand factor helps in that, but it exists in two forms. It exists in one form, which is a multimer. It's a big von Willebrand factor, and then it exists in the form after it's cut up by atom TS13 in a little form, which is monomers. Now the monomers aren't sticky, so they won't cause platelet aggregation, but the large multimers of von Willebrand factor will. Well, what happens is the immune system goes awry and creates antibodies to actually block or fight atom TS13. So when this atom TS13 is blocked, it's like it's put a sheath on the sword. It can no longer chop up von Willebrand factor into the smaller monomers. So now all the von Willebrand factor is clumping platelets together. So it clumps all your platelets together all throughout your blood and causes all your platelets to be used up, inducing thrombocytopenia. So that's how you get to the part of thrombocytopenia. And those clumps it's made are the thrombus or the clot. So that's your thrombotic part. So now you have a higher chance of bleeding because your platelet counts are so low. So what can the clot formation do? Well, much like in DIC, those clots go out into the distal microcirculation and clog those up, causing you to get into states of lactic acidosis. They also clog up the distal circulation, especially in areas of high cardiac output, like your brain they can go to, your kidneys. In fact, anywhere your blood can travel, you can have platelet aggregates or clumps of platelets, so you could have an MI induced by this. But there's a pentad that's usually tested on of signs and symptoms for TTP, and those are neurological issues, microangiopathic hemolytic anemia, which we'll go over in a minute, kidney issues caused by the clots going into the kidneys, fever seen in 50% of these patients, and because it clumps all your platelets and use them up, you get a thrombocytopenia. So that's the normal pentad tested on, but essentially platelet clumps can get stuck in anywhere that they can lodge, anywhere your blood circulates. So what do these platelet clumps do when they clog up in that microcirculation? Well, if you have them clogging up some of the circulation and red blood cells are being pushed over it, and as they're passing across it, just as like in DIC with this fibrin, it can split those red cells in half. So as it passes across the platelets, it can split them in half, and as it cuts those red blood cells in half, they no longer can carry oxygen, and they become what's called schistocytes or helmet cells because they're half of a circle. Just think of a little half circle, and they look sort of like a helmet, so it's called a helmet cell. So when you see schistocytes or helmet cells on a peripheral smear, you should think microangiopathic hemolytic anemia. The difference is in TTP versus DIC, TTP induces more of a hemolytic anemia. So LDH is found in red blood cells when they're damaged. So you're going to have super high, 2 to 3 times the level you would expect from normal of LDH and TTPs. Whereas in DIC, you may have slight elevations, as a lot of the elevation in LDH and DICs are more related to tissue damage, where this is going to get both of them. So what else is different with TTP? Well, these are platelet clumps, not fibrin clumps. So we're going to have that low platelet count, but it's not going to be using these clotting proteins as part of the process of making thrombus. So if I measure in TTP my intrinsic pathway or a PTT level, I'm going to see that those levels are normal. If I go over here and I measure the extrinsic pathway for a PT or an INR, I'm going to see those levels are normal. And that's different because in DIC, I'm going to see high PTT levels, I'm going to see high PT levels because I've used up all these factors. In TTP, only thing I've used up is all my platelets. So these levels are going to be normal. Other thing is I saw a low fibrinogen in DIC because I used up all my fibrinogen to make fibrin clots. Again, I'm not using this pathway. Thrombin's not went wild like it did in DIC. So my fibrinogen levels should be normal. Fibrin that was used to make those clots, as soon as they're made, if we remember from the DIC lecture, they immediately start to be broke down and they release those fibrin split products out, which are like D-dimer. So where in D-dimer, my D-dimer may be super elevated in DIC. If I look here in TTP, I'm not going to see super elevated D-dimers with TTP. So that's another thing that can help differentiate these two. Now, the other big thing is how do we treat it? In DIC, I was given cryoprecipitate to try to keep my fibrinogen levels up and support clotting. I may give platelets as I used up all and consumed all my platelets as well. I'm given FFP to replace all these clotting factors. Now, in TTP, the problem is with just platelets. So you could say, well, I just give platelets since the platelets are low, and that should fix it. The problem with that is I have von Willebrand factor as a multimer. So if I give platelets, I cause more platelet plugs, more platelet aggregation, and I send clots more places. Now, I have heard of hematologists at time with severe brain bleeds giving platelets anyway, because it's just a matter of life and death at that point. But the majority is, the rule is you're not going to give these because these are going to clog up. So what am I going to do? Well, in your plasma is where your atom TS13 is found. So what we're going to want to do is we're going to want to do a plasma exchange. We're going to pull that bad plasma out with that useless atom TS13 that's been sheathed and made useless by all those antibodies sticking to it. And you're going to want to replace it with fresh plasma that has plenty of atoms TS13. So it'll be able to chop that von Willebrand factor up and to make it monomers. Now the other thing, since it's immune mediated and it's actually antibody production, is they may give corticosteroids, and that's going to be to sort of blunt that immune response so you're not just pumping out antibodies all the time. So in that way it's different. Sometimes there's a monoclonal antibody they'll give in some of these. So the treatment approach is really based toward that immune response, and it's also based to plasma exchange in order to get the patients the bad plasma out that contains useless atom TS13 and to get it replaced with good plasma. Another huge difference you'll see, this is a primary condition. So if you have someone with sepsis, someone who amniotic fluid embolism, you've got snake bite, all those things that would use up this coagulation pathway, then they start bleeding a lot and their plasma count's low, you're looking at DIC because it's a secondary condition. This condition exists by itself, so this person just doesn't feel that well, or they come in and you get some random labs, or they're noticing bruising all over, and you get some labs and their platelet count's low, and then they get a smear and they find schistocytes. Then they're like, well, let's get an LDH level, and they get it and it's through the roof. Maybe they have some neurological issues, some kidney dysfunction, but there's nothing else going on. You can't find anything, a primary cause that could be leading to secondary DIC. Their D-dimer is not elevated, their fibrinogen's fine. So this is going to be on the differential, is it's a potential TTP. And if you ever wonder why, and especially for our testing, why the provider didn't order platelets for this person that's went into TTP, and you're giving steroids and you're getting them ready for plasmapheresis, that's the reason, is this happens in a different way than DIC. So that's the management of TTP, and that's what TTP is, and also the differences between DIC and TTP. If you like this video, please like and subscribe. We're going to have some more content up for CCRN review shortly.